Shivaram, we are ready.
Good evening, everybody. I welcome you all to this South Zone meeting of the AWR surgeons. I'm very happy that our president, Dr. Punjani, and also Dr. Pramod Shinde, who are the backbones of this organization now, have joined us. This is a great movement which started by Dr. Ramana, and then it has cut up and has spread all over the country and doing excellent work in the hernia field. The abdominal wall reconstruction, which is the most thriving and progressing and prosperous field in the field of general surgery. And I'm sure this will emerge as a unique specialty in the time to come. And in that effort, the contribution of Indian surgeons to the entire world is enormous, and it has taken a great momentum. I welcome you all to this academic endeavor, and I request Dr. Punjani to say a few words, and after that, Dr. Ankit will take over. Thank you all. Enjoy the meeting. If you have all the queries, please put in the chat box. We will take in between. Thank you all.
Thank you, Shivaram. It's really a pleasure to see that we have started our activity with a bang in the South India. And Ankit Mishra who is right now taken a lead in Andhra Pradesh is really, we are going to go at a faster pace. Let me tell you, this abdominal wall reconstruction concept has been in India. I think the first publication occurred somewhere in 2015, and we have formally started 2016 onwards. And 2017, 18, 19, we had a conferences, and that grew so much interest that this small community of handful of people has now turned into a huge community of nearly around 5,000 people. So we have got a AWRSC, how we call it, Abdominal Wall Reconstruction Surgeons Community. And we really actually live in the principles like a community. So we don't have any formal sort of bylaws and formal sorts of rules, but like a family we are there. And we have taken this particular concept of abdominal wall reconstruction further. So we don't no longer look hernia as a whole or just a patch that needs to be done on a whole, but it is basically a reconstruction, entirely a different concept. Now this concept of what we call it a component separation started in 1990 where AWRSC actually took up the world after about 2000. And many of us have started doing it for quite almost a decade. But we thought there has to be a formal training and a formal way of addressing this issue. So that's the reason that this particular community is formed. And Ankit is one of a very enthusiastic member. And I mean, he has taken a lead with all the seniors like Shivaram and Tirumala Prasad and Premchandran and everybody. So it will be a great to see. And Ankit, can you just take over further now for the meeting?
Thank you, Dr. Punjani. Thank you for those kind words. I am really very grateful to everyone who has joined us on this Sunday afternoon. The concept of concept is not something new, but I have often found that people reach out and ask, what exactly do components mean? We have come really far off in this field of herniology, but there remains quite a few doubts in many of us to understand the technique of component separation. But this isn't only about operating. The concepts of components have to be understood right from the basics. So we decided why not to have a small webinar which will benefit us all, a seasoned surgeon or a student who's becoming a surgeon. So hierarchy is now going to matter. We will break down these concepts to the very basics. So let's start with something which is basically the foundation of components. I would like to invite Dr. Ashwin Thangavelu to start off with his talk on anatomy. Dr. Ashwin, over to you, please.
Thank you so much, Ankit, for that kind introduction. So today I've been given a tough job to talk and basically lay the foundation of what the components of the abdominal wall are. So there is a very nice saying which says that, you know, what the mind doesn't know, the eyes don't see. So it is very imperative that we train ourselves as surgeons in the anatomy of the abdominal wall so that we can have a smooth surgical procedure and also understand the various investigations and interpret it, how it will be useful for us in a practical manner. So with this, I will just go on directly into the talk. So when we talk about the abdominal wall, it is very important that we understand what are the boundaries of the abdominal wall. So just put simply, superiorly you have the costal margin and the xiphoid process. Laterally you will have the mid-axillary line. Inferiorly the pubic symphysis, tubercle, inguinal ligament, and the iliac crest along with the ASIS. This would constitute the boundaries of the abdominal wall. Next, when we talk about facial layers, we have two components. One is a superficial facial layer, the other one is a deep facial layer. So when we talk about the superficial facial layer, it is going to be constituted by the skin, the subcutaneous tissue. And when we talk about the subcutaneous tissue, there are predominantly two portions of it. One is the superficial fatty layer and the deep membranous layer. Above the umbilicus, these two layers are not very well developed. They seem like a single layer. Whereas below the umbilicus, we can very nicely identify the superficial fatty layer, also known as the camphus, and the deep membranous layer known as the scarpa's fascia. When we talk about the deep facial layer, it is constituted by the rectus sheath, the rectus muscle, the external oblique, internal oblique, and transversus abdominis. This understanding is important because whenever we are trying to categorize a infection or the plane where the surgical site occurrence has happened, this would come in very handy. So now here, when we take an individual with a very low fat percentage, you can very well identify a small linear flat line-like structure in the midline. So this is nothing but the linea alba, which is formed by the anterior and the posterior rectus sheath. And then you have the rectus muscle on either side. You can see the tendinous inscriptions, either 3 or 4. And then laterally again, another flat line-like structure seen on either side, which is nothing but the linea semilunaris. So when we talk about the retrorectus space, it is going to be limited by the linea alba in the midline and by the linea semilunaris laterally. And the green space in between is going to be the retrorectus space. So if you see, they are actually two separate different spaces. And if we need to combine and connect them together to perform a good sublay repair, I'll just touch upon a little later in my talk how to go about it. So now when we look at how the muscle orientation is present in an individual, so here in the midline, you can see bang in the midline on either side, you have the rectus abdominis muscle. So basically these muscles would originate in the lower abdomen, in the pubic symphysis and the pubic crest, and it would go and get inserted into the 5 to 7 costal cartilages. So this is the first protection which is present in the midline. Then when we come laterally, you can see the direction of the fibers. So these fibers originate from the lower 8 ribs and they run in an inframedial direction, and they get inserted into the pubic symphysis and the pubic tubercle. So that is how the direction of the fibers are. And then deeper to the external oblique, you will have the internal oblique. Here you can see the direction of the fibers of the internal oblique. They originate inferiorly and run supramedially, exactly perpendicular to the direction of the external oblique, which is the thickest muscle. So here you can see how it is originating from the lateral half of the inguinal ligament, the iliac crest, and it will run above and get inserted into 10 to 12 ribs. So this is how the insertion would happen. And you can see how both these muscles are complementing each other. Then the third flat muscle which we want to talk about is the transversus abdominis. Here you can see the transversus abdominis running in a horizontal direction. So you can see how all these muscles have been planned to act as a very good corset for our abdomen and act as a good protection, as well as have a good functional outcome for our human body as well, for the flexibility and all the various rigorous activities we will need in our day-to-day life. So these muscles, as you can see the direction of the fibers, they generally originate from the lateral half of the inguinal ligaments and even from the costal cartilages in the ribs. And then all of them, they even have a few fibers interdigitating with the diaphragm, and they will run towards the medial part. Medially, they become an aponeurosis and split into two supraumbilically. The anterior lamella will aponeurosis will actually join and form the rectus sheath over here. So this is how the anatomy would look like in the anterior abdominal wall. So now when we look at this image, you can see the image above arcuate line. So here you have the internal oblique, which is dividing into an anterior lamella and a posterior lamella. This anterior lamella will join with the external oblique upper neurosis and form the anterior rectus sheath, whereas the posterior lamella will join with the transversus abdominis and form the posterior rectus sheath. And you can see how the anterior and the posterior rectus sheath are enveloping the rectus. And you can see here, this will be the linea semilunaris, which is the limiting factor. And here in the midline, the anterior rectus and the posterior rectus will join to form the linea alba, which will be the limiting factor for the retrorectus space on this side. Below the arcuate line, you can appreciate that the posterior rectus sheath is absent and we have only the anterior rectus sheath.
Dr. Ashwin, can you
Yes,
use
sir?
the pointer? Can you use the pointer?
Sir, I'm actually using it right now. You're not able to see it, sir?
Not able to see, no? Chat box, there are
Okay.
a lot of requests.
I'm actually using it, sir. I don't know why it's not visible on the screen. Can I just stop my share and restart?
No,
Probably
continue.
see if it works.
I think, no, continue. Yeah, okay.
Okay, sir.
Continue. You have stopped now.
Sir, it may not work on Zoom, the pointer.
1 second, sir. It was working earlier in presentations. I don't know if any software updates and changes have happened.
Yeah,
so can you see my presentation now?
Yeah, yeah. Yes.
Is the pointer visible, sir?
Pointer not visible. You go back, there it will be visible. Now it's visible.
Now is it visible, sir?
Yeah, yeah. Yes.
Is this okay if the screen is smaller?
Okay, continue.
Okay. So next, we would just briefly touch upon how the vascularity of the abdominal wall is split. So here we have 3 Huger's classification. One is the zone 1, which is nothing but the central abdominal wall. And this zone 1 will be supplied by the deep superior and inferior epigastric arteries. So next we will have the zone 2, which is nothing but the lower abdomen. And this lower abdomen will be supplied by the superficial epigastrics, circumflex iliac, and external pudendal. And you can see how the direction of these vessels are running on one side. This is the right side, and left side also you will have a similar mirror image kind of a vascular distribution. Now when we talk about zone 3, you can see here that the vessels are actually running just parallel to the inguinal ligament and then start dividing into multiple small branches. So here predominantly the vessels which supply the vascularity are the lumbar arteries, the musculophrenic, and the intercostal branches. And on the right side, you can see an image where you have the nerves which are present. So the sensory nerve supply for the abdominal wall is between T7 to L1. Don't try too much to understand these terminologies or have it by heart. It's just for a brief overview that I'm mentioning you. And then the motor is going to be by the lower intercostal nerves. But what mainly I want you to understand with this 2 slides is that 1, the neurovascular bundles run between the internal oblique and transversus abdominis, which essentially means that we will never do any dissection between the internal oblique and transversus abdominis, no matter what type of a component separation we are going to plan for the patient. And also the zones of vascularity, why it is important is, if we already have an incision, like say a subcostal incision, then we know that the vascularity over here is going to be altered. So when we are going to do a newer incision, we should keep in mind and not cut off the vascularity coming from the opposite side or from the lateral side, so that the SSOs can be kept to a bare minimum. And similarly, if we have a incision say in the paramedian, then we know that the main vessels probably which were running in the retrorectus space is being taken down. So that means we might probably have to excise a little wider portion of the skin to make sure that we do not have any flap necrosis happening in that area. So now certain diagrammatic presentations just to give you an idea of how the coronal section of the abdominal wall would look like. So we have the rectus abdominis muscle on either side. We will have the external oblique, which will be the thickest of the flat muscles. Then we have the internal oblique below the external. And then we will have the transversus abdominis muscle. So all these three flat muscles will be present laterally, and the rectus abdominis will be seen in the midline. So here we will have the posterior rectus sheath, which is being formed by the posterior lamella of the internal oblique joining together with the transversus abdominis. Same way on the opposite side as well. And then you will have the anterior rectus sheath, which joins with the posterior rectus sheath to form the linea alba. And the anterior rectus sheath is formed by the external oblique aponeurosis and the anterior lamella of the internal oblique. So this is how the coronal image of the abdominal wall would look like. And here again, you can see how the retrorectus space is limited medially by the linea alba, and laterally you have the linea semilunaris, which will be in this area. So then we will have the peritoneum, which is the deepermost layer we have, and then you will have the major vessels which we were talking about, which will give multiple perforating branches and supply the subcutaneous tissue and the skin in this zone. So when we talk about the infraumbilical area, the posterior rectus sheath is not going to be present in this region. So here we will only have an anterior rectus sheath, and here we can see that there is a dotted line, which is nothing but the transversalis fascia, and this transversalis fascia will be very visible and easily can be dissected also in the lower abdomen. So anteriorly you can see it is only the anterior rectus sheath, and here you can also see the nerves which run between the transversus abdominis muscle and the internal oblique. This is why it is important that we do not do any dissection between these two flat muscles. So when we talk about anterior component separation, what generally happens is, this is the area where we have the linea semilunaris. So anywhere between 1.5 to 2 centimeters lateral to the linea semilunaris, we will incise the external oblique aponeurosis like this, and then we will develop the avascular space and plane between the external oblique and the internal oblique muscle, and we will just keep dividing in this place up to we enter into the retroperitoneal area, and that will give us a good mobilization of this anterior component, which will help us in closing all these large midline defects. So when we want to talk about the anatomy for a TAR, posterior component separation, here actually if you look at the CT images in the lower abdomen, the transversus abdominis muscle does not stop at this level laterally, whereas it comes much more medial. So this is the rectus muscle, and you can see the transversus abdominis muscle comes much more medially. So this is contradictory to the image which we generally learn in our surgical training. So I just wanted to emphasize that point. Why it is important is, when we want to do a posterior component separation, what we have to do, the first step is to incise the posterior lamella of the internal oblique, and then you will incise the transversus abdominis over here at the insertion point, and then we will develop a plane between the transversus abdominis muscle and the transversalis fascia. So here you can see the dotted line of transversalis fascia. The TA muscle should be bare, and we should not see any muscle after we do a good TAR, and this again is carried out up to the psoas or into the retroperitoneum based on the amount of mobility we would require. So just briefly to show you a diagrammatic representation how a minimal invasive ETEP RS would look like. For a right-handed surgeon, we generally prefer to start in the left retrorectus space. So here we insufflate and open up the space nicely. You can see the linea alba, the falciform, and you can see the limitation of the retrorectus space. So here we are not able to connect both the spaces. So for this, we need to perform some maneuver. So the first maneuver we have to do is incise the left posterior rectus sheath before it gets inserted and forms the linea alba along with the anterior rectus sheath. Once again, we don't divide the linea alba. We divide it around 1.5 centimeters before that, proximally, and this is only the posterior rectus sheath. So we divide the posterior rectus sheath. Then in the superior abdomen, we will see the falciform ligament, which we will push it down. And once we push it down, we can see the linea alba superiorly, and again we will come across the posterior rectus sheath of the right side. So here we will incise the right posterior rectus sheath as well. And then we have communicated both the retrorectus spaces. So now a little more dissection on the carbon dioxide, you can see it is a good retrorectus space which we have divided. We have not breached the peritoneum, and the falciform is the added security which we have in the superior abdomen. And if it's a small hernia, after the dissection and repairing the defect, we would place in the mesh in this retrorectus area. So thank you very much for your patient listening. I'd be happy to take any questions you guys might have. And sorry about that pointer once again.
Dr. Ankit, you're there? Thank you, Dr. Ashwin. I think that was a wonderful talk. Any questions from anybody and comments? Somebody had raised the hand. You can unmute and please ask the question. Ankit has some power failure problem. Anybody has any comments or anything? Right. Ashwin, I think that was a wonderful talk. Thank you very much. Dr. Shinde, you have any comments? Unmute, please. Unmute. Can't hear you, sir. Okay, if there are no questions, we'll move on to the next talk. Anterior component separation technique by Dr. Pramod Shinde, one of our senior hernia specialists. Dr. Shinde, please. Dr. Shinde, you have to unmute.
Yes, now I was able to unmute. I was not able to unmute because unless the host unmutes me, I will not be able to speak.
Oh,
so
okay. You are able to share your presentation?
Yes, I'll do that right away.
Okay.
Can you see my screen now?
Yes.
Okay, and you can see my mouse moving also.
Yes, we can see that.
So after a very nice talk by Ashwin, and since he has already delved into details of anatomy, my task has been easier. So I will restrict myself only to the anatomy necessary for the procedure. I will not be going into the details of the anatomy. So I must first of all congratulate the AP chapter and the South Zone, Dr. Shivaram, under his leadership, Ankit and all his colleagues who have actually planned this wonderful program. So the mandate given to me is the anterior component separation, and we all see ventral hernias, and some of them can be pretty large. It may be quite large, ranging from 8 to even 20 centimeters. And the closure of defect has been shown to have a number of benefits to the patient. And we may be forced to do something in an emergency or a desperate situation like this. And in fact, there is a grade C recommendation that for the closure of defect, additional component separation facilitates the closure and should be used for larger defects. So anterior component separation was proposed way back in 1990 by Ramirez, where he demonstrated that external oblique muscle can be separated from the internal oblique in a relatively avascular plane, and large defects right up till 18 centimeters could be closed. Of course, that was the era of anterior component separation where mesh was not being used, but nevertheless, he had demonstrated something very unique, and this became popular in the next decade after. So to understand the anatomical basis of component separation, we need to understand the abdominal wall anatomy. So here we can see the external oblique. Now this muscle not only covers the entire anterior abdominal wall, but it covers almost a little more than half of the chest wall also. And this fact can be made use of in the anterior component separation. The other fact on which the anterior component separation rests is that if we look here, between the external oblique and the internal oblique, there are no nerves traveling. All the nerves travel between the internal oblique and the transverse abdominis. So this aneurologic plane was made use of by Ramirez to do the anterior component separation. So what he proposed was, he proposed that we raise the skin flaps, go beyond the linea seminaris, and incise the external oblique lateral to the linea seminaris. Once that was done, in fact, he added a retrorectus incision also, which is not popularly known to be associated with anterior component separation. So once that is done, then the cut edges of the external oblique could be widely separated. You could go between the external and the internal oblique, dissect out this space, and because of this divided edges of the external oblique, then this component of the rectus muscle, the internal and the transverse abdominis, along with the neurovascular bundles, can then be actually pulled medial. So you raise the skin flaps, divide the external oblique, dissect between the external and the internal oblique, and then you can pull the rectus abdominis along with the rectus sheath and the lateral abdominal wall towards the midline to close the midline defect. So once the midline defect is closed in the midline, then you could put in a mesh in any plane that is appropriate for the patient, and onlay mesh goes all the way to the lateral divided edges of the external oblique, or you could put a sublay mesh or even an intraperitoneal mesh can be put after you have closed the defect. What this does is you are able to close close to 20 centimeters of defects in the umbilical region. Whereas at the other end, near the symphysis sternum and the symphysis pubis, you may be able to close defects up to 8 to 10 centimeters or even 11 centimeters. So this is a short video of an open procedure where we first start with adhesive lysis. We take a very generous incision from the symphysis sternum towards the symphysis pubis, and once we do the adhesive lysis, then we start raising the skin flaps. Now these skin flaps are raised so that we are able to go beyond the linea seminaris. Okay. So, and here you can see large skin flaps are being raised. You can actually roll these skin flaps with your hands, and then once that is done, the surgeon can actually hold the rectus muscle in his hand and then go beyond the linea seminaris and divide the external oblique right from the costal margin here towards the inguinal region. And then he can dissect between the external and the internal oblique also. This is an avascular plane, a neurologic plane. And once there is an adequate separation on the left side or any one of the sides, then you can move on to the other side to do a similar division. Again, you can see the external oblique being divided. And once that is done, then the midline closure becomes fairly easy, and you could put in a large onlay mesh. The advantage of onlay mesh is that you can suture the lateral edge of the mesh to the lateralmost divided edge of the external oblique. But sometimes the recti are so widely separated that you may have to do a lot of dissection, raise large skin flaps, then repair it with a large mesh like this, and then the wound looks fantastic for the first 2, 3, 4, or 5 days. But the problem is that because the perforatus has been divided, it is known that the component separation can give rise to skin necrosis. And then the wound can break down like this, leaving the mesh exposed. And then most of the times the mesh can be salvaged, but then there's a prolonged morbidity with a rack dressing. This patient might have to go on for either 2 to 3 months or maybe even 4 months so that the entire mesh can be salvaged and wound can be healed. So we all understood that somehow if we can keep these perforators intact, then the skin necrosis will not be so much troublesome. So the Dumanian group proposed a periumbilical perforator sparing component separation, where they propose that if we leave the umbilical region along with the subcutaneous fat attached to the abdominal wall and develop tunnels around it, then the skin necrosis will not be there, and you'll be able to do a similar anterior component separation by going lateral to it and developing tunnel like this. So this can be done by leaving it in technique, taking an incision in the subcostal region on both sides, and then dividing the external oblique laterally without raising the skin flaps, and then coming to the midline and closing the midline. So this is again one variation which can minimize or prevent the skin flap necrosis. But Lau et al. Actually did it in an even more unique way. In 2000, what they did was they put in a balloon between the external and the internal oblique and started doing an endoscopic anterior component separation. So endoscopic anterior component, extensive skin flaps were, mobilization was avoided. There were less wound complications, shorter hospital stay. Obviously, the mesh that could be put in this scenario was much smaller than what you would put in an open onlay technique. Various techniques were tried, including a nephroscope, a single port, but then the endoscopic anterior component separation could be done as a subcutaneous technique by going between the subcutaneous tissue and dividing the external oblique from top down, or in a sub-external oblique aponeurotic technique where you could go between the external oblique and the internal oblique, and it can be done along with open ventral hernia repairs or a total laparoscopic ventral hernia repairs, or you could use it to close the abdominal wall without putting a mesh in such kind of scenarios. So in an endoscopic anterior component separation, again, the aim is to divide the external oblique lateral to the linea seminaris, go between the external and the internal oblique, dissect out that space, and then close the midline defect. So Jorge Dias was the person who developed this subcutaneous approach, and he does it very elegantly. This is his video where he marks out the linea seminaris, puts a balloon to develop the subcutaneous plane, put two working ports, and then expose the external oblique by dividing the deep fascia. And then the external oblique can be divided right from the costal margin towards the inguinal region. You can see the yellow fat. Generally, we don't see the muscle because this space is covered with fat. And then you can separate these edges, that's the costal margin, and you can do the same thing on the other side. And once you have done this endoscopic component separation, you could go back, in fact, to the peritoneal cavity and close the defect and put in a laparoscopic IPOM dual mesh by doing an IPOM plus. Again, another video of our patient which had a recurrent incisional hernia with bowel contents, and these contents were reduced. You could see the previous mesh there. Now, the epigastric ports can be pulled out to actually do a subcutaneous endoscopic anterior component separation. So the same laparoscopic port is pulled out, and the subcutaneous space is accessed in the costal region, and then you start developing the subcutaneous plane, and you're on top of the external oblique now. That's the external oblique. And then you can start dividing the external oblique, and the dissection is pretty avascular. You can see the external oblique aponeurosis here, and the CO2 also helps you, but you also have to separate the edges actively. And this can be done very nicely as a subcutaneous endoscopic anterior component separation. Once you do it on one side, you can pull out the mid-clavicular port on the other side below the costal margin and do it on the other side, and then go back to the peritoneal cavity and close the defect laparoscopically. I particularly favor the sub-external oblique approach, where you can expose the external oblique, pick it up, divide it. You can see the internal oblique there, develop the space between the external and the internal oblique, and then once you put in the camera port and the working port, now the external oblique is on the roof and you are in an avascular plane, the internal oblique is on the floor. So again, this is an open incisional hernia repair video where there was a large epigastric hernia right from zipisternum to subumbilical region, almost 11 centimeter defect. So we did an open incisional hernia repair, but the component separation was done endoscopically. So again, a very short video. That's the epigastric defect. So the first step is again adhesiolysis, because we want the abdominal wall free. Then we start raising the skin flaps, but these skin flaps are raised in a very limited manner, only up till the future midline. We don't go all the way laterally. So once this limited skin flap mobilization is done, then that's a defect. And then you take a small incision just above the anterior superior iliac spine. This is a 15 millimeter incision. Identify the external oblique, pick it up, develop space between the external and the internal oblique, and then put in a simple 11 mm trocar for your camera, start insufflating, and you are below the external oblique, lateral to the linea seminimalis. Now we are looking on the right side towards the head end, we are going towards the costal margin. So now you can see that the space can be enlarged. You can already see the costal margin there and the external oblique. Now these are the muscle fibers, because we are going above the chest wall here and we are below the external oblique. So we can now start dividing the external oblique on the roof using a simple scissors or a hook, and the muscles, the aponeurosis and the muscle fibers can be divided. Now the advantage of this is you can go all the way up till the 6th intercostal space to divide the fleshy fibers of the external oblique, because this is an epigastric hernia. So this is the advantage here, where you can go above the chest wall, and then you can go laterally like this, bisect between the external and the internal oblique, and then enlarge the cut towards the inguinal. You also have to divide the deep fascia fibers to get a better mobilization of the edges. And once the cut edges are widely separated, you could leave a drain there and do the similar procedure on the left side. Separate the cut edges of the external oblique and then go back to your open incisional hernia repair. So it can be very well combined with an open incisional hernia repair, where the mesh can be placed either in an onlay plane or in a sublay plane, and we can do a very nice repair. Similar cases here. This is a large lower abdominal hernia where the retrorector space has been destroyed by these retention sutures. We are going to hear about the abdominal wall closure maybe later, and nice closure can be done. Again, this is a post-traumatic patient with a skin graft there and widely separated red patch. Obviously, this needed an open incisional hernia repair, but the component separation was done endoscopically, and the patient was walking on the next day. So this is endoscopic component separation is a pretty useful procedure, but it can be done also as a totally laparoscopic procedure. Now, this is again a video of a female patient with a lower abdominal hernia defect of about 7 to 8 centimeters. We are starting laparoscopically with 3 epigastric ports and looking at the hernia from top down. So here you can see that this is a recurrent hernia. You can see the previous mesh there. So we do the adhesiolysis. Then we measure the defect. The defect is not going to close. So now the right subcostal port, intraperitoneal port, is pulled out, and the external oblique is picked up like this, and you put in a port on the right side in the subcostal region, looking towards the inguinal region. And we are already lateral to the linea seminimalis. You can see beautiful loose areolar tissue. So you put in a working port, start enlarging that right subexternal oblique space, and we are going towards the inguinal region on the right side. Now here you are already lateral to the linea seminimalis. So there is no worry here. And you can start dividing the external oblique. According to Ramirez's principle, this is what we are going to do. So the edges start separating with the CO2, but you also have to actively separate those edges and also divide the deep fascia. In fact, you can go back to the peritoneal cavity to check whether your mobilization has been adequate or not. So you can check. If not, you can go back to the subexternal oblique space again, do a little more lateral dissection between the external and the oblique and the internal oblique. Okay. Divide the external oblique towards your camera port, divide the deep fascia. And once you feel that the separation has been adequate, then you can move on to the left side now. This is the left subcostal port, the same intraperitoneal port pulled out and put below the external oblique. Here you could see a fantastic finding of an iliohypogastric nerve traversing this space. Once that external oblique division separation and component separation has been done, then you can go back to the peritoneal cavity and close the defect. Now the defect closure becomes quite easy, and then you can put in a dual mesh and do a laparoscopic IPOM plus. So obviously, complications can be there like any other component separation or hernia surgery. You could have a post-operative abdominal compartment syndrome, you can have wound infection, seromas, flank bulges have been reported, but recurrence rates are similar as will be seen. Obviously, loss of domain is something different, which needs a separate management, which we are going to hear about in the later part of this program. We should be careful not taking up patients above the BMI of 40. We have to optimize them. A recurrence can happen and comorbidities have to be controlled. Now, there are some very nice papers. Now, in this systematic review, an open anterior component separation was compared with TAR, with endoscopic anterior component separation and a perforator preserving component separation. And here it was seen that the SSO is comparable between all these techniques. You can see that it was 21%, 23%, 20%, 16%. In fact, incidence of recurrence also, here it was seen that it was highest when using the anterior open anterior approach at 11.9%, but otherwise the recurrence rate was comparable between posterior component separation and even endoscopic component separation. Now, even this was studied that are there differences between perforator sparing and endoscopic component separation and the posterior component separation. So here it was seen in this study that the surgical site occurrences were again similar. The recurrence rates were similar between all three. And based on this systematic review, there were no relevant differences identified between the perforator sparing, endoscopic anterior component separation, and even the posterior component separation. So, my friends, component separation is a new armamentarium which has now almost become very popular and spread all throughout. Every new armamentarium comes with its own set of problems, failures, and learning curve. Not every patient will require a component separation. Pre-operative optimization is very important and must be done. We should not violate virgin spaces for future repairs because any repair can fail. And a selection of a patient with proper procedure done for that patient will save a lot of heartburn. Thank you.
Thank you, Dr. Shinde. I know the time doesn't do justice for such a vast technique, but I mean, the graphics and the videos that you had put were absolutely outstanding. I'm really very, very happy that this was done by you, one of the pioneers of ACSTs in India. I have a few questions for you, sir.
Yes.
Do you concur with this statement that people who really want to venture
Ankit, not audible.
Yeah, Ankit, I'm not able to hear you.
Meantime, we'll take some questions from the chat box, Dr. Shinde.
Yeah, tell me.
Okay. Dr. Srivatsa is asking, what is the lateral limits of dissection which are the kept in open? Can't hear him. Okay. Hello.
Yes. See, the lateral limits in open or endoscopic techniques are similar, but in an open technique, you can go almost beyond the mid-axillary line. Okay, you can go, obviously the costal margin and the iliac crest will be the limiting factor, but you could go way beyond the mid-axillary line. Okay, in an endoscopic component separation, we commonly find that we are easily able to go up till the anterior axillary line and up to the mid-axillary line. Beyond that, it becomes difficult. So endoscopic anterior component separation is slightly lesser in its division, in its dissection, and its results also. If we have a very massive hernia, then an endoscopic component separation will not be able to give you the same kind of release like an open anterior component separation.
Dr. Shinde, what are your thoughts on ACST in emergency settings? Dr. Pinnock wants to know.
Yes.
Any
Well,
role?
anterior component separation has been used in emergency settings for abdominal closure, and it has been used for even reducing the abdominal intra-abdominal pressure. And it is a great procedure to help you close the abdomen. So there have been papers, many centers have used it so far, but now that we are moving towards abdominal wall reconstruction and core abdominal health, today the general recommendation is not to use component separation for abdominal wall closure. We could use other techniques, maybe temporary abdominal wall closure techniques, the open abdominal techniques, the VAC techniques, and like that, and come for a planned closure of the abdomen, rather keeping any form of component separation for a more formal repair of the abdominal wall. So although in an emergency setting, it is acceptable if you need to use anterior component separation for midline closure, if you can avoid it, that is better.
Thank you, Dr. Shinde. There are some more questions you can answer in the chat box. That will be grateful. Because of time, we'll move on to the next speaker, Dr. Parthasarathi from JAM Hospital. He will speak on posterior component separation technique. Thank you very much, Dr. Parthasarathi, for joining us.
Good evening, everyone. First, I'd like to thank the AWR South Zone office bearer, Dr. Shivaram sir, and Dr. Ankit, and Ramesh Bunjani sir, and Pramod Shinde sir, and other senior Prasad, other senior member of AWR South Zone, to giving me this opportunity to present the posterior component separation technique. And I think someone else is already shared the screen.
Dr. Shinde, can you stop sharing? Or anybody else is sharing, please stop. You're able to share, Dr. Parthasarathi?
It is not, I think, Shinde sir's screen, is somebody else, I think.
Anybody is sharing, please stop sharing.
This is Dr. P.K. Gambhir.
Dr. Gambhir, can you stop sharing? I can't do that, I think. So I'll make your screen. Can you do that now, Dr. Parthasarathi?
No, it shows that.
Okay. Dr. Ankit is the admin.
No, are you able to see my screen?
Yeah, now we can see. Now we can see.
Okay. Then I'll do that.
Please continue.
So thank you once again, and very good evening to all. And after the very well informative lecture of Dr. Ashwin, anatomy of abdominal wall, and a very good talk of Dr. Shinde about the anterior component, and I'm going to talk on a posterior component. So commonly the E-tape or Reeves Toba, it has some limitation, and it's a limited medial myofascial advancement and lack of sufficient sublet space in case of larger defect. And if you do lateral dissection, and chance of neurovascular damage will be there. So Yuri Nowitzki developed the novel technique, that is the posterior component separation. I'm going to talk now. So this is the mesh size of the regular retrorectus repair. And this is the right anterior linea semilunarius and the left linea semilunarius. And upper abdomen, you can go to the xiphoid and lower up to the pubic bone. So you cannot go laterally. So further, the component separation developed for the larger defect management. And initially it was divided by Matthews et al. He described the space between external and internal. And carbonyl, he demonstrated the space between internal and transverse abdominis muscle, and it has a lot of neurovascular damage. And then finally, the Urinovitsky is the one, he developed the novel technique of posterior component separation. And so I'm going to, that is called a transverse abdominis muscle release. Basically, he released the insertion of transverse abdominis muscle at the level of linear semilunaris level at the postector sheath. It is attached. So it is released, divide the transverse abdominis muscle so that it will give a medialization of the rectus muscle and closure of the large defect. So this is the advantage of TAR, that is a transverse abdominis release. So it allows for a significant posterior rectus fascia advancement and wide lateral dissection. We can go lateral dissection between the TA muscle and the post layer of transversalis fascia up to the psoas muscle, or even if we can go to the quadratus lumborum also, particularly in lumbar hernias. And it allows the preservation of neurovascular supply to the rectus abdominis muscle, and it provides the larger space in a sublate space, larger space for mesh in a sublate space. And most importantly, medialization of abdominal wall component without raising the lipocutaneous flap. So without any anterior or superficial flap raising, we could be able to achieve this medialization of the abdominal wall. I think this anatomy is covered with Dr. Ashwin. And so what is the indication of TAR? It's laparoscopically, and we can, it is literature says up to 8 centimeter defect, we can go for a TAR approach, and open any size, any defect, we can go for a unilateral or bilateral TAR, depends on the situation. And it is important to point out that the TAR should not be combined with the anterior components release. Suppose if you find difficult, if not approximate, then if you should not combine the anterior component separation on the same side, it will produce the laxity of the lateral wall, and then in future the lateral wall hernia formation may be there. And suppose the patient had recurrence after the anterior release, after the anterior component separation, the patient had a recurrence, you can go for a TAR, posterior component separation on the same side. And then in that case, you have to keep a large, heavy weight mesh to accommodate to give a strength to the lateral abdominal wall. Pre-operative planning is like regular hernias, strict glucose control and smoke cessation and the respiratory exercise. And the technique, I have video, I'll explain in that during the time of video. And this is the way we used to put a port, and this case is a very huge defect. You can see the very large defect, more than 12 centimeter in the supraumbilical, and here is a divarication. So this is a 4-port we used to put, and this is the way we keep a stand on the head of the patient we operate, and then any supraumbilical dissection we come to the left side of the patient. In case of bilateral TAR, with this 4-port, I can able to make the unilateral TAR. And this patient's large defect required bilateral. I put 2 extra port, so we can go a laparoscopic TAR on both sides. Left side with this port, and then right side with this port is possible. So this is the way we do, and this is the completion of the surgery after closure, after PRS repair, and then lineal closure. You can appreciate this. It is totally bulges disappear. And this is the, I didn't show that now, and I don't want to show the normal E-tip RS, I think everybody knows. And in this case, it is after release, it is very difficult. It's a large defect. So it is not approximating the postector sheath. So I start the TAR release. And usually I start in the upper one. It is a top to bottom approach. And we have to find out the neurovascular bundle, and then we start we're placing the postector sheath, start closer to that. And here I went medial to the TAR muscle attachment, and then I went, now it is a lateral to, this is the long plane. So I reach the right plane. I reach the lateral to the attachment of the TAR muscle. The hook is the ideal one, and it is basically, it is a release of linear semilunaris. You should not divide the postector sheath. You have to release the linear semilunaris so that the postector sheath released from the attachment. So now I started dividing the release of the TA muscle. And I'm using here, it is the Allen forceps. It is a bipolar coagulation and cutting forceps, so that without any muscle twitch or bleeding, we can able to divide it. So now this is again, I started releasing further, and we have to be careful about the neurovascular bundle. So this is the one of the neurovascular bundle. It's every 2 to 3 centimeter distance, we could see the neurovascular bundle. So we have to be careful when we release. This is another neurovascular bundle is in the view, coming near to our dissection. So it's separated. So it is go away, it goes above the, or it goes on the abdominal wall along the inferior. Now we can see after the TAR, it is part of the PRS is released. And this is the attachment of the, when we coming down, that is below the umbilicus level, it's more of aponeurosis. You can see here it is a more of aponeurosis. The TAR muscle is placed very well laterally. So this is the post-arcuate line. So from there it is going to the anteriorly to attach to the rectus sheath. So now it is when we coming down, you can see TAR muscle is going laterally, TA muscle is going laterally, and this is the aponeurotic portion of the area. So now I divide the transverse abdominal muscle. The posterior, what we are seeing is the post layer of transversalis fascia, and below that it's a peritoneum. So this is the way of doing a transverse abdominis release. And when we coming to the upper side, our upper abdomen, and it is coming very much medially, and we have to careful. If you go laterally, then you will injure the nerve, and then diaphragmatic fibers also will be injured. So TAR on the lower side will go laterally, and the upper side will come medially. So after this release of TAR, then we close the anterabdominal defect, wall defect, with a non-absorbable suture, and here I'm using a number 1 PPT. And I'm started close at the defect, and simultaneously the linea alba to be closed. And by doing release of the PRS, post-rectus sheath on either side, and it will produce some kind of widening of the linea alba around 3 to 5 centimeters. So we need to close the linea alba. So the linea alba is closed. Now you can appreciate here up to the level I divided. So finally, I used to, even though it is a locking suture, I used to put a Aberdeen's knot at the end, because it is abdominal wall, it will give me more pressure. So I finished the suture with the Aberdeen's knot. So the post-rectus sheath is being closed, and here we are using a 1-0 PDS, that is a V-lock suture, a locking suture 1-0 with absorbable, delayed absorbable one. Again, it is coming up to the, from what level you divide up to the what xiphoid or epigastric region, up to what level we have to suture it. So now it is anteriorly linea alba closed, posteriorly PRS is closed, and it is a good space. After there is no tension in the post-rectus sheath. That is very, very important. That's why we are doing a TAR approach. There is no tension, and this is the suture line, and this is the TAR area. And after that, we keep the mace, and then we can suture, and then we deflate the case. So this is basically about the TAR procedure. And this is another case. I complete the TAR. That is the arcuate line. Up to arcuate line, I divided, and from here it is only the transversalis fascia post layer, and so that is the post-rectus sheath, and this is the TAR muscle. Attachment is divided, and I'm just trying to approximate the post-rectus sheath. So it is it's not possible. It is very tension, it is under tension. So I have to do another side TAR, or I have to do the posterior component separation. Now I started mobilizing started a posterior component separation, separating the post layer of transversalis fascia from the TA muscle. So this will give around more than 5 to 10 centimeter separation, so that the approximation is very much easier. So this is I'm getting a space between the post layer of transversalis fascia and the TA muscle. Initially, small attachment with the small maybe there that can be divided with the this bipolar forceps. So you have to find out the plane, and thin layer should be covered the muscle. TA muscle should be covered with a thin layer. Then your separation will be easier. So just I'm getting the plane now. So I'm separating the TA muscle from the post layer of transversalis fascia. So now after, usually once you divide the TA muscle, that is after TAR, you will get around 3 to 4 centimeter, 3 centimeter most of the cases. And if not possible, if you find difficult to approximate the PRS, then you can go for this PCS, that is a post-component separation. But you have to be careful about the traction with the left hand, and you should not injure the post layer of transversalis. It is not a peritoneum. If it's a peritoneum, it's easy to injure with my left hand forceps because I'm pressing down. So if it is, since it is a post layer, 2 layers there, it will give a good support. You can see how much pressure I'm giving with my left hand, and it is not injured the post layer of transversalis fascia. So sometimes what I did, I take a gauze piece and then I hold with the so after a little bit release, and you can see it is almost around 5 to 6 centimeter space I can able to get, and I want some more space. And so after release, now you can see it is very easier. This is the right plane. So now I enter into the right plane, and with this plane I can go up to the lateral border of psoas muscle. That is called the safety area. No, that is safe area, safe mark. Otherwise called safe mark. That's Urinovitsky mentioned like a safe mark. So this type of gauze piece, pressing the post layer of transversalis with the gauze piece, so that wider area is being pressed. So injury to the post layer of transversalis will be avoided. So or any blunt forceps, you can use it. And I prefer this Allen forceps. It is a blunt tip and a small vessel. That is a normal, that is a tissue layer is covering the post layer TA muscle. So that is a plane. With this plane, we can enter into the laterally, even up to the psoas muscle. Laparoscopically, comfortably we can do. So my indication of laparoscopic approach is literature-wise is 8 centimeter. It's even 12 centimeter to maximum 15 centimeter. We can go laparoscopically by doing a bilateral TAR with post-component separation. So last video I just showed the TAR, and this video how to do the component separation. I'm just demonstrating it now. So now it is divided. Each muscle is seen nicely, and you can see it is more than 10 centimeter. I dissected very comfortably. I keep the instrument, and usually the instrument stores instrument from the tip up to the mark, K level. It is 5 centimeter, and then you can see it is almost more than 10 centimeter is dissected. The same way we can coming down, and this is the level of arcuate level. So I'm separating the post layer of transversalis from the TA muscle. So it is a very well possible. Or you can put another instrument. You can push up the muscle with a separate instrument. If you push up the muscle, and then you can push down the post layer of transversalis. This space is very well developed, and then any big defect we can able to go by laparoscopic approach. Unless if it is a skin changes or skin graft or skin necrosis, there is no need for open. We can manage laparoscopically with bilateral TAR with the PCS. So in case of very huge hernia, and we can go for an open RS with the bilateral TAR. So in that case, we have to keep a mace like this. And usually a larger case, I used to keep the mace of 50 centimeter into 50 centimeter, big size mace. So it will cover from the right of psoas muscle to the left of psoas muscle comfortably. It will accommodate with a single piece of mace. And I could see only the Merrill company has right now with the 50 by 50 centimeter mace. So this is one of the case, very 4 times operated, and then I did an open TAR for this case. This is the rectus muscle and then post rectus sheath. The TAR is being started. So after this, I closed the post rectus sheath around. I could get around 8 to 10 centimeter space, and then this is the post-operative view of the after this surgery. So this is one of the challenging cases with the loss of domain, and even the CT shows all abdominal organ, including kidneys outside. And this patient cannot lie down in a supine position, because he has to turn once to laterally then only he can able to lie comfortably. So this is one of the difficult one, and he underwent 4 or 5 laparotomies with colostomy and one surgery, transverse colon injury. 2 times colostomy was done. I did this post-concomitant bilateral open post-concomitant separation. I kept the 50 into 50 size mace. Now you can appreciate he is comfortably lying on the supine, and then he walked. It is around the 4th or 5th day in the room itself. I took this video, so he walked comfortably. So this is the advantage of very huge hernias and open bilateral. This patient, even I didn't even tried PPE or any Botox injection. Even the TAR CT wise, no lateral abdominal wall is assessed, and then good bilateral TAR able to close this abdomen. So I like to conclude like this. It is a TAR is rapidly becoming one for a common approach for a major abdominal wall reconstruction. It has 3 main advantage, and the first one is significant medial mobilization of the post-rectus sheath, so that it will create the good extraperitoneal pocket for the mace. It allows the extensive lateral dissection between the transverse muscle and underlying transversalis fascia or peritoneum. Some patients, post layer of transversalis will not be developed. So that I have shown a video of developing the space between the TA muscle and the transversalis fascia, so that it will allow the sublay placement of the mace to reinforce the entire visceral sac. And finally, it will provide medialization of the rectus muscle and linea alba to reconstruction of the majority of the complex abdominal wall hernias. And this reconstruction is not only provide the durable repair, but also facilitate the restoration of physiological properties of the repair of abdominal wall. So the medialization of the rectus muscle, the physiological function is also improved. So with this, I will finish. Thank you so much. And any questions, I'm ready to take.
Thank you, Dr. Parthasarathi. That was a crisp talk. I really love the high quality videos that you share for everyone's learning. And there are a few questions. What I am seeing, because I had to log out because of power failure and I'm back in. I see Dr. Naz Sheikh asking, lamppost sign and volcano sign, are these well appreciated? Do you in your practice always follow these? Do you always look for lamppost sign and volcano sign?
Yes.
Okay. And we have Dr. Satyakumar asking, laparoscopic PCS repair, is there any role of pneumoperitoneum causing difficulty to reconstruction of linea alba? Do you think pneumoperitoneum is a hindrance as compared to open approach?
See, when we are doing a regular E-tape, we divide the post-rectus sheath. And if it is when you are starting initial period, if it is any small rent in the post-rectus sheath, then it will produce a difficult loss of space in the extraperitoneal. If you open up, it is like a door, both intra-abdominal and extraperitoneal, the space pressure will be equal. And only thing, when you are doing a PCS TAR, you have to be careful about the post layer of transversalis. There is not any buttonhole or any injury to the peritoneum or post layer of transversalis fascia.
Which actually is part of the next question. Someone is asking if there are holes in the posterior layer of PRS complex.
So it is, if you have a tear in the post wall of post layer of transversalis or peritoneum, we have to suture with the PDS. Usually I used to do with 230 PDS, continuous suture, and it should be closed properly. You can go for some more PCS, some more mobilization, and then suture with the PDS is good. And you should not leave any small defect. Even a small defect is not advisable because of the abdominal pressure. The omentum or bowel can come inside. It will produce the internal hernias. So it is advisable to check the entire dissected area. There should not be not even a small hole. We have to suture all the hole.
So has it ever happened in your experience that there was
I have done loss? Even I have a video. What happened is after the TAR, I approximate the post layer of transversalis, and initially for first I can say around 50 cases, I used to keep the 5 mm port in the subxiphoid area before closing the post rectus sheath. So I place under the camera, under vision, I place the subxiphoid 5 mm port. So that is for after the entire surgery, I used to take the 5 mm scope intra-abdominally, and then I could see how it is inside. And is there any bowel or momentum is caught when we suture the mace? So what for that case, one day instead of usually I put the left subsified area, and one case I just put a right subcostal. I put a trocar before placing the mace. It will injure the post layer of transversalis fascia. The momentum is coming up, and then I find very difficult. I did the PCS and then I sutured. I placed the mace and then I put a transabdominally extra trocar, and then I suture it with the transabdominally also. So it is very difficult. Once you, that is the main disadvantage of TOR and PCS. Once you damage the post-ictus sheath or the transversalis fascia, and then it will become very cumbersome. Even the tension, no, it won't approximate nicely, and you have to mobilize the posterior component well. Then you can suture the defect.
Okay, quickly, my last question to you. Do you have any experience with redo TARs or redo ETEP RSs?
So far, no. It is I couldn't do any case, but I have done a lot of recurrent hernia. Recurrent hernias, IPOM recurrence or open with ACS recurrence. I have done TAR, but ETEP TAR recurrence I have not seen so far.
Right. Thank you. Thank you very much, Dr. Parthasarathi, for that informative talk. So one can argue that you can never stop learning. And that's precisely why you have to challenge the status quo. Our next talk is by Dr. Prem Kumar Balachandran on what's new in component separation. Over to you, Dr. Prem Kumar. Dr. Prem, you're on. You have to unmute yourself, Dr. Prem.
Prem, we can't hear you.
Dr. Prem?
No. There's some problem with his connection, I think. Ankit, can you unmute him? He's unmuted.
He is actually, but I can't hear him. Dr. Prem, can you hear me? If you can, change your slide and I'll know that you can hear us.
He can hear us, we can't hear him. Shall we go to the next talk and come back so that he can get ready? That's okay with you, Prem? Okay, so stop sharing so that who is the next speaker?
And that's you, sir.
It's me, okay.
Yes.
Okay, let me share my presentation. I am audible?
Yes, you are. We can see your screen as well.
You can see my slides?
Yes, we can.
No. You can see?
Yes.
Okay. Good evening, everybody. Thank you all for joining in large numbers. We were full. Ankit has put a lot of efforts. Thank you, Ankit. Let me quickly go on to the loss of domain. As it is self-explanatory, loss of domain means the contents of the hernia have lost its boundaries and they have come out. And the standard definition has still now elusive, and there are a lot of efforts. And this is, many people say, you see the hernia, large, massive hernia, you will realize there is loss of domain. It's a clinical situation when more of the viscera is outside the abdominal cavity than inside. Usually, it is assessed by the CT scan, but again, there is controversy whether you have to do the CT when the patient is lying down or when the patient is straining. Abdominal cavity is unable to fully accommodate the abdominal contents within its facial boundaries. So when you operate on such a difficult case and it is impossible to close the fascia, it can lead into high intra-abdominal pressures, facial dehiscence, or abdominal compartment syndrome with all its problems. When you see this, it's very obvious that these are most difficult hernias and the post-operative consequences can be very, very serious. Even since 1997, there are many definitions which people have tried to put in: defect more than 10 centimeters, more than 20 centimeters, or whether it is the abdominal contents which has come out more than 50% or 20, 25%, all these things. So basically, the few objective measures, not many, and consensus definition is still people are trying to find out. What I can say is when there is not much of contents inside the abdominal cavity which has come out, you can easily close like this bag and there is no tension, the bag is strong. Same thing we do in the abdominal hernia also. This patient, you can easily do whether open, laparoscopic or E-tap, whatever it is. But when this bag is torn and a lot of contents have come out, it is very, very difficult to close this bag. Similarly, when you have a massive hernia, you have to keep wondering what other methods we can do to give a relief to this patient. So that is what we are talking today. And even as long as early as 2019, there is still debate about the loss of domain definition. And this systemic review says that there are multiple definitions and it is very difficult to standardize yet. And there is a standardization which is required. So that's why this Delphi consensus meeting was held in Greece and they tried to sort it out with the consensus proposals of the surgeons who gathered there. Basically, they tried to explain these two, whether it is Sabaga method or the Tanaka method. Sabag method, where there is loss of domain, is calculated as a percentage of the total peritoneal volume. In Tanaka method, it is the ratio of the hernia sac volume. So there is, it's almost similar, but the expression is different. But Tanaka method is known to most of you, and this is much more popular. So whether you go in both ways, so calculations is the ultimate thing is the same thing, but the ratio of the hernia sac volume to abdominal cavity volume, that is defined in Tanaka method, and it comes in these fractions. In the Sabaga method, it is percentage. So there are many things assessing the complexity of ventral hernia by methods of Tanaka, Sabag, Corbonell, Lau, all these things, and I think this debate will continue. But I found this proposed classification system by Michael Rosen is more appropriate to all of us. Basically, you have to see whether there is contamination or not. Can I say contamination? Whether there is any intracutaneous fistula or ulceration, skin infection. These can cause a very serious problem when you are doing a massive ventral hernia. And the size of the hernia defect and size of hernia sac and abdominal contents within it. Once you assess these three things, then you can see in the contaminated, again, small defect with massive hernia, massive defect with massive hernia, or non-contaminated with massive defect, small defect with massive hernia, and massive defect with massive hernia. So this becomes easier for us to take it forward. Contaminated hernia, we have to be very, very careful, and it should not be taken lightly. The effects of this loss of domain leads to poor quality of life, loss of core muscles, backache. A lot of patients come when they have massive hernias with backache because it changes the spine curvature, and it can impair the respiration, cardiorespiratory embarrassment or difficulty, and the mesenteric edema, poor bowel function, as I said, skin erosions or enteric fistulas, and obviously the cosmetic issues. Some of them may be indications to operate, but what we should know that when we should not offer repair. This is very important when we are dealing with massive hernias with loss of domain. If the patient cannot tolerate the hernia repair, like poor lung function, morbid obesity, chronic smoker, and repair will not improve the quality of life. If you are not able to improve the quality of life of a patient, what's the point in operating? Repair will lead to significant post-operative complications. You do a good repair, but you push the patient to the ICU and ventilator. That is not the good way to deal with it. And if the surgeon doesn't have the expertise of this, how to manage loss of domain, or the hospital doesn't have the facilities for this major undertaking, then also it should not be done in that hospital. As you all agree, a living problem is better than a dead certainty, as it is said. So when you see a large ventral hernia, you have basically three options. That is, if the facilities are okay, if you are trained, you can operate yourself. Otherwise, if the patient definitely requires surgery, better to refer them to a good center and a surgeon who has experience. Or if you think that this patient will not tolerate the surgery, better not to offer any surgery for such patient. Maybe you can do a multidisciplinary meeting with the anesthetist or another experienced surgeon, and then decide that this patient does not require surgery and he may not tolerate the problem, then better not to do that. If the patient, you have decided that it has to be operated, as I said, the first thing to do is a good CT scan, probably a contrast study, and some of the software also available with the radiologist. Now we can definitely estimate the volume of it. What is important is to check the body mass index, the diabetes control, the lung issues by doing a pulmonary function test, cardiac status, and if necessary, a multidisciplinary team meeting with all the involved stakeholders. Loss of domain, if it is massive, it requires optimization. You can see here, when there is too much of this tension, there is no point operating like this. This is going to give away. We are pushing too much inside and somehow closing with tension sutures. This is what used to be done earlier, and the patients were sent to the ICU, ventilator, all those things. Now we have better methods to manage these things. This is one of our patients, which patient had a massive ventral hernia, and BMI was 46 with multiple comorbidities. The first thing we did was to reduce her weight by doing a bariatric surgery, sleeve gastrectomy, and then waited for a year. Her BMI came down to 34, and finally we could do a good, strong repair, and the patient, even after 2 years now, has doing a good mobility, activity, everything. Her main problem was backache, this patient, and of course the massive hernia which was pulling. So ladies and gentlemen, how to achieve the tension-free repair and manage loss of domain. This is very, very important in massive hernias. Anyway, you have been now explained about the component separation techniques, but some of them definitely require optimization. We have two important tools to come over this loss of domain. One is the Botox injection, which is also known as the chemical component separation technique, and the pre-operative progressive pneumoperitoneum, and other methods like visceral reduction and tissue expanders or flaps, which are used not of the many of the AWR surgeons. Reduction of the intra-abdominal contents via resection of visceral organs was practiced earlier, but nowadays most of the surgeons don't practice it, like hemicolectomy, omentectomy, or small bowel resection. Once you do this, there are chances of more complications, problems, and bowel leak or contamination of the mesh. So nowadays, this is not a good option. Then you have tissue expanders and flaps. This is basically the domain of the plastic surgeons. They do a good job of it using the tissue expanders, either in the subcutaneous expansion that may not be very good. Interparietal expansion is possible between the muscles and get additional relaxation of the muscles and the intraperitoneal volume. Fasciocutaneous and myocutaneous flaps, some of the plastic surgeons do, whether pedicled or free flap. This is another option. But what the most of the surgeons, AWR surgeons, believe is in either Botox injection or the pre-operative progressive pneumoperitoneum. How to do this botulinum toxin injection to abdominal muscles? This is the good method where it causes temporary flaccid paralysis of the external oblique, internal oblique, and transverse abdominis muscles. And once you inject it and the effect starts, it can last up to 6 to 9 months so that compartment syndrome can be avoided. If you are planning this for a loss of domain patient, it should be given 4 weeks prior to the surgery. The dose is 300 units mixed with 150 ml of normal saline. That means it becomes 2 units per ml. And on both sides, using an ultrasound guidance, 25 ml is injected on each side or each muscle, or 25 ml to each muscle. That becomes a good relaxation of these muscles. And after these injected on either side, right side for the internal oblique, external oblique, and the transverse abdominis on both sides using the ultrasound guidance. Then you wait for 4 to 6 weeks. This increases the abdominal volume and allows for a good midline closure. If that is also not helping, or you can use pre-operative progressive pneumoperitoneum. This is not a new technique. As long back 1940, Moreno has insufflation of the air or gas into the abdominal cavity pre-operatively to gradually expand the abdominal volume, and this accommodates the hernia contents which have gone out of its boundaries. So this lengthens the abdominal musculature gradually, physiologic preparation of the patient, and there is adhesiolysis. So how to do this? So what I do is progressively distend the abdomen with air in OPD or as a daycare patient. Our first step is to use an ultrasound guided catheter to peritoneal cavity, either a pigtail or a peritoneal dialysis catheter. This can be best done by an interventional radiologist, or if we are doing ourselves, we can take the patient to OT under laparoscopic guidance. We can put a tube if that is feasible. Then daily inject air through the indwelling catheter. using a 50cc syringe, about 800 to 1000 ml daily, or till the patient feels mild discomfort and he feels full. So easily 800 to 1000 can be injected, and this can be the air, and duration is about 10 to 14 days. In about 12 days, there will be good expansion. The pneumatic dissection of bands and adhesions, and the whatever bowel loops or contents have come out, they will go back into the abdominal cavity. Finally, we can do a good midline closure. So effect of pre-operative progressive pneumoperitoneum, I have already mentioned. Progressive distension of the abdominal wall, elongating the muscles of the abdominal wall, and this increases the abdominal cavity volume, which had shrunk because the contents had gone outside. Pneumatic dissection, it again facilitates the viscera to return back to the abdominal cavity. Most importantly, it stabilizes the form and function of the diaphragm, and the ventilatory function it improves. Hernia defect can be finally closed with least amount of tension, whether you do a refractus repair or a TAR repair. If you see this CT, this is the baseline CT, and this is after post Botox injection. Transverse diameter has increased, but if you do both post the Botox and also the pneumoperitoneum, there is all the contents have come back, and the, whatever is there outside has totally. Dr. Ankit, can you mute the person who is talking?
I am on it. Dr. Jayesh Kothari, you need to mute yourself. Dr. Kothari, kindly mute yourself, please.
You can mute Ankit.
Yeah, I'm on it.
Okay, thank you. So this is the effect of Botox and the progressive pneumoperitoneum, which allows for a good repair and midline closure. So this is a small video where we faced this problem. This was a transverse incision post necrotectomy, massive hernia, progressive pneumoperitoneum being done for 12 days. After that, we did this CT, which shows all the contents have come back to the abdominal cavity. I didn't remove the air which was injected that helped for the dissection. The video is fast to adjust for the time of this presentation. What I want you to see that how easily we can close the posterior rectus sheath and the rectus sheath after the TAR surgery. It's an open TAR which was done for this patient. Anyway, Dr. Partha has nicely explained the posterior component separation of the transverse abdominis release. Once we do that, you have a good amount of the posterior rectus sheath, peritoneum, and the closure becomes excellent. So it's mobilized, and because of the progressive pneumoperitoneum and also because of the TAR, you can see there is no tension in the midline closure, and using a PDS suture, this can be closed, and then you can put a large mesh. And these patients, when we spend so much time pre-operatively, they need not go to ICU or the high dependency unit, and they are very comfortable to breathe, and there is no compartment syndrome or the respiratory embarrassment. You can see it's easily coming out to close, and the pneumoperitoneum and the TAR has done its work, and that is the post-operative results. Sometimes we may not be able to press ourselves too much, so we have to do a staged repair. That's also explained in case of loss of domain. So if there are enterotomies, bowel obstructions, or gangrenous bowel or a very sick patient, loss of domain emergencies, don't push yourself too much. It's better to lose the time, and again you can win the war again, lose the battle, but ultimately you can win the war. First stage, deal with the primary problem, later optimize the patient, and finally take the patient and do a good mesh repair. That patient will be very happy. So in the past, we all have burnt our fingers by taking these patients without optimization and preparation, and large defects, closed under tension, then go to ICU, post-op complications. And if you see the literature, up to 50% of them, they can recur. With the AWR techniques, which we are all talking today, we can at present have good results with proper pre-operative optimization. And sometimes whenever required, we can use the progressive pneumoperitoneum or the botulinum toxin injection. Excellent methods we have. And the large defect probably requires a component separation to close in midline without tension. ICU rarely required. Post-operative complications are very less, and these patients will be the happy patients with good results at the end. And the recurrence rate can be reduced to 5%. So 50% to 5% is a big jump, and I think all of us should look at these things. So friends, to summarize, loss of domain poses a significant challenge to the surgeon. Unfortunately, we don't yet have a good standard definition, and we should thrive at a go for a consensus for this. And these patients, when there is loss of domain, require a good optimization before surgery. And as I explained, the Botox and PPP are very useful adjuncts in these patients. Decision making is the key to success in all these patients, whether to operate yourself, or some of them have to be denied surgery, or the patients who can withstand the surgery should be sent or referred to a higher center with a good experienced surgeon. Thank you, ladies and gentlemen. Thank you. Ankit?
Well, that was fantastic, sir. I totally loved the simplicity of your talk and how heavily it was based on concepts. We do have a few questions, sir, and I'll take them one by one. So, Dr. Satyakumar asks, can Botox in LOD cause difficulty in defecation as it can alter intra-abdominal pressure?
No, because this is not so much causing discomfort. Actually, Botox gradually releases. It doesn't cause any of these difficulties. And when we are doing this progressive pneumoperitoneum, we are not overdoing it to the point of discomfort to the patient, and it is done over a course of 12 or 14 days. So there is no such problem. Ankit?
Then we have Dr. Sheikh. Can you hear me?
Yes,
Dr. Sheikh asks, is there a role of abdominal corset after surgery? What is the ideal duration which they can be used?
Yes, abdominal corset definitely is useful, and it should not be too tight so that they cannot breathe or anything, but it gives a good compression. And we use for about 1 or 2 months, not too long. If you use it for very long time, they can weaken the abdominal muscles. And once the abdomen stabilizes, it is better to teach them the abdominal wall exercises so that the muscles are strengthened for a short time to prevent the seroma formation, and for the comfort of the patient, especially when they have post-operative period. This can also make them better mobility. So that way there is a role on this abdominal corset for some time after the surgery.
Okay, we have another question from Dr. Hiremat, who says, if PPP adhesions are there to the abdominal wall, patient may have pain, or will it cause traction on the loop?
No, it is not a sudden thing which is occurring. It is occurring over the course of 1 or 2 weeks. So the adhesions release and the contents which are there inside the hernia cavity coming back to the abdominal cavity is a gradual process. So I have not seen any of these patients having difficulty unless you push too much of the air or anything. Dr. Punjani or Dr. Shinde can come in. I think they have more experience, or anybody else. Dr. Shinde?
Yeah, can I say something?
Yes.
So on the contrary, what happens in pneumoperitoneum is it leads to a lot of adhesions are broken down because of pneumoperitoneum. So what I've seen is that when I normally insert the catheter by a laparoscope, so I have an idea of adhesions inside. And when we actually open, we realize that a lot of adhesions have actually vanished. So pneumoperitoneum gradually dissects those adhesions and makes the surgery a little better. But I think what I like about the Shivaram's lecture is that every time he has cautioned us when not to operate. So please don't be in a hurry to take up these patients. You can actually kill a person. So I think that, to put it a little crudely, but I mean, one has to be really careful. I think Pramod wants to say something.
Well, that was an excellent talk, Dr. Shivaram. There are 3 things that I'd like to add from my side. One is we have to take care of 2 patient factors. One is the respiratory status and continuous spirometry and respiratory exercises, because the pneumoperitoneum is going to push the diaphragms up. And the second thing is DVT prophylaxis with LMWH is important during this PPP, even Botox. So that is very important, that all throughout the patients have to be protected against pulmonary embolism and DVT. Third difficulty is most of the times the air starts going into the hernia sac and the actual abdominal muscles don't get stretched. So the patient's corset has to be tightened and the patient has to be taught, and every time the patient comes to us for refilling of the air, we have to check and see that the corset is not being loosened and the air stays inside the abdominal cavity more than the hernia cavity.
Excellent points. Yeah. Yes, Ankit.
All right, so we'll take the session ahead. Dr. Prem Kumar Balachandran was having some technical to be speaking next until he fixes his technical problem. So I'm going to share my screen.
Yeah. Ankit will be talking about imaging black and white of component separation technique. You're not able to share?
Just a sec. Can you see my screen now?
Yes, yes.
All right. Good evening, everyone, and thank you very much for joining us for this first South Zone AWRSC webinar on concepts of component. All the talks have been stellar till now, and I'm going to touch upon very quickly about abdominal wall imaging. So abdominal wall reconstruction is currently the hottest selling cake of general surgery, and everyone wants to get on board and learn these technical nuances of these newer procedures. But I tell you that it's all incomplete and can actually backfire if you're not good with your radiology. I understand that you are a surgeon and you should leave that job to a radiologist. But if you want to avoid surprises and not have a bad day for a bad abdomen, you should actually start giving some time for radiology. I am Dr. Ankit Mishra. I come from Live Life Group of Hospitals, Hyderabad, and AWR is my specialty. For disclosure, me and my dear good friend, we started a surgical initiative where we are trying to bridge the gap between surgeons and a radiologist. We are calling this hernia cat surgical radiology. This is mainly focusing on developing radiological skills amongst the new and young surgeons, as well as the seasoned surgeons. The other disclosure is, please have a very good radiologist friend standby. Don't be a sole radiologist. You are a surgeon. You should have your surgical sixth sense for interpreting the scans, but don't overdo it. Let's start with the simplest thing that most people confuse about. When you have an abdomen with a hernia to scan, you should really know what your protocol should be. Your patient lies supine in the gantry. If you feel that there is an occult hernia, ask the technician to take thin slices of 2.5 millimeter. Most of these scans will not need contrast. If you have to give contrast, if you think your patient has the indication to give contrast, like an active infection, EC fistula, active bleed, then the contrast is mandatory. And if possible, try to give contrast and see the scans in delayed or post-arterial phases. Nowadays, we are fighting a pandemic, but there has been a pandemic before, which is the oncologists are equally affected by this pandemic of obesity. When you send these patients inside gantry, this is the kind of picture you get above the scan, because that part was not part of the scan, as the scan's FOV was not optimized. Don't worry, you really don't have to do much about it. All you have to do is tell your technician to call the software engineer from the company who has provided CT scans to give you the correct software for optimization. Remember, CT scan is just a camera which is capturing the image, but all that reconstruction is happening in that computer. And unless you ask for it, you won't get it. So all these images can be optimized and you will not lose a bit of it. So you don't really know what's happening at the top of this area, whether there's an infarcted bowel, is there an omentum, is there an EC fistula? You're kind of lost. So if you go ahead and operate this patient with this film, there are chances, high likely chances that you will land up with problems. So fix this. I simply want to tell you that if you follow this rule of 3, 2, and 1, you won't miss most of the hernias. I'm sure you will miss some of them at some times, but by following this simple rule of 3, 2, 1, you will catch hold of most abdominal wall hernias. Let's start with 3. We are always looking at the midline and fishing for hernias. That's why I want to take your attention to the lateral side. So our lateral flat muscles are 3 muscles. Ashwin has given a stellar talk on the anatomy of it. Let me just give you a black and white picture of that. So the outermost we have here is the external oblique, below which we have the internal oblique, and the innermost is transversus abdominis muscle. Let's take a look in a different perspective of an ultrasound. I am a very pro ultrasound because I like to scan the abdominal wall myself. I know this is not completely laid down in the books. This doesn't go by the books, but I truly believe when surgeons pick up the ultrasound probe, they fish out more and more information that a radiologist tend to miss. So I like to scan my abdomens myself, and it's actually a fun thing. So the same thing what we are here, the outermost is the external oblique, followed by internal oblique and the transversus abdominis muscle. A word here by linea semilunaris. Now, linea semilunaris is actually a tendinous intersection of the aponeurosis of the muscle. It actually provides flexibility, but does not give any strength. So it's potentially a weak area of the abdomen. So this is important for you to understand the orientation and how it looks in black and white. You need to train your eyes now to look at these things in black and white. Let's talk about a muscle which has created or probably started the revolution in hernia surgery. So the muscle we all know is the transversus abdominis muscle. It's like a corset wrapping up all around, but it's not a straight line, mind you. Right at the top, you see, we have fleshy fibers of transversus abdominis muscle. And that's where the myth comes. The transversus abdominis doesn't stop at linea semilunaris, but in fact goes all the way midway, or even in some patients to the midline for insertion. So the fleshy fibers at the top is what tells you where your transversus abdominis muscle is. The legend, of course, is the Urinovitsky, who took the leverage of this detail and devised the procedure of transversus abdominis release. In the center, what you are seeing is the rectus abdominis muscle highlighted in the red color. Now, ideally, your TA should have ended at linea semilunaris. But let's see what happens. When you put in more colors to this, you see that the TA is going well beyond the midway of rectus abdominis muscle, almost close to your linea alba, which is not missing in this very picture. So your transversus abdominis is traveling way more beyond than linea semilunaris. And on the top left corner of your screen, you are seeing a picture which is taken from an ETEP procedure. You're seeing the fleshy fibers of TA. It's encroaching your posterior rectus sheath, and laterally you have your linea semilunaris. So mind you, this is an important thing that you will be noticing on scan. The same is seen on CT scan. As you may see, there are images of transversus, fleshy transversus going well below and past linea semilunaris at the top. So if you have to look for transversus abdominis muscle, look at the top. Again, referring to that image, we have our transversus abdominis muscle. When you're looking, always remember to look at the top. If you try and look it down from the bottom, most of it is usually eponeurotic or have other important structures there that may not give you the confidence to pick them up. Doing a scan focus, which in case of hernia is dash, dynamic abdominal sound for hernia, always start from the top. And that applies for CT scan too. So your transversus abdominis muscle starts at the top, a fleshy fiber going well past the linea semilunaris behind the rectus abdominis muscle. Now let's apply the knowledge of 3 to this scan. What we are seeing here is a post-operative patient. He has undergone twice hernia repairs. Now let's see what we find here. Now on the right, if you may look, the transversus abdominis is going well past linea semilunaris, almost up to the midway of the thick rectus abdominis muscle. But if you compare that to the left, you will find that the transversus abdominis is retracted laterally. And that's because this patient had undergone left TAR, because he had a recurrent hernia post-onlay. So that retracted muscle is the transversus abdominis. So if you find a patient who's probably undergone a transversus abdominis release as per the notes, you would want to confirm that again, because a lot of the time a surgeon has divided some structure and documented it as TAR. But you do the scan, you find the transversus muscle right at its anatomic spot. So by comparing this, you know if the person has undergone transversus abdominis muscle or not. If there is loss of muscle because of previous surgery, you know that your planes are going to be frozen up there. That's why it's important when you're looking at any muscle component, be it external oblique, internal oblique, or transversus abdominis, you need to look for their complete integrity, their planes, and if there is any missing component in it. So this is where you see the transversus abdominis has retracted. Let's take a look at the other scan. Okay, I'm pretty sure you have spotted the one in the midline. Congratulations. But I want you to look harder. As I said, we tend to look only in the midline for hernias. That's probably a reflex that we have generated in ourselves. But I want you to look harder. Is there something else that you are missing? Let's go back to the rule of 3. We know we have 3 flat muscles on the flank. On the right, it's looking perfectly all right to me. We have all the 3 muscles intact. But let's see what's happening on the left. So you can see that hyperend structure. You will have to mute yourself. You're seeing that the fat is herniating there. And then there is no integrity of the lateral flat muscles. They should ideally be connected to the rectus abdominis at linea semilaris, but there is a gap through which the fat is herniating. So now I've highlighted my rectus abdominis and flank flat muscles. You see the fat is completely going beyond its domain. But is that all? I'm seeing transversus abdominis, internal oblique. But what about external oblique? Right there it is. So this is actually an intraparietal hernia. This is not breaching all the layers of the abdomen, but only a few layers. They still have an
I think we lost Ankit again. Ankit?
I am back. Can you see me? There was a glitch.
You mute your video. I think we can listen to your audio.
Okay.
I think now it's better. You can mute your.
Can you see me?
Yeah.
We're not able to see the slides, Ankit.
Just a sec. I started sharing my screen, and can you see the screen now?
Yes.
Yeah. Ankit, you take out your video so that the audio will get a better presentation. If there is a net issue.
Yeah, that's better.
Yeah, that's it.
All right.
Yeah.
All right. Let's get going. So we have a layer of internal oblique on top of that hernias. More often, these hernias are missed because we are not actually actively looking for them. Very, very important in such cases is to add Valsalva. So in your protocol, you should have Valsalva when you're suspecting such occult hernias. And if you really actually are trying to find out the integrity of complete abdomen, because you will find these hernias in certain patients who have undergone surgery previously, such hernias are common, especially in IPOM where you take transfacial fixation to the mesh. These hernias are common. Port site hernias, when your port goes through linea semilaris, these side hernias are common. So you must actively look for them. What else your 3 tells you? Again, look at the flat muscles. So on the right, I'm seeing there is complete disconnection from its insertions laterally. And then there is an incisional hernia which is formed. What about this one? Essentially looks normal, right? But let's apply the knowledge of transversus abdominis here. And let's see if we find something. So on the left, the transversus abdominis is looking pretty all right. But what about on the right? It appears to be retracted. But mind you, this is a normal anatomic feature. Your transversus abdominis is not a straight line. It is curved. So your fleshy fibers turn laterally and your aponeurosis go all the way inside medially. So that particular appearance is absolutely normal. This is not a TAR. I told you, if you have to look for TAR, look up top. Right at the top, then only you can define or understand if the person has actually undergone TAR or not. I cannot leave a procedure alone. This is very, very important. From a paper published by Dr. Jorge Diaz, this patient has undergone a release. How to find out? On the right, the external oblique muscle you're seeing is about 5.92 millimeters from the lateral border of rectus abdominis. But on the left, that's 7.75 millimeter. Mind you, in any of these repairs, we don't cut the muscle. We are cutting the aponeurosis in ACST especially. So here we find, without not giving you enough knowledge, tells you a lot about what your patient may have undergone, what kind of surgery he may have undergone. Again, applying the rule of 3. This is a patient who has undergone twice hernia surgery and had a recurrence, so he underwent, you can still be able to understand the probable course of surgery that he had undergone in the past. Let's see how. Let's zoom right in and apply the layer as external oblique. I'm seeing internal oblique. I'm seeing transversus abdominis. But what is that? Can you concur with me? What is that? There's something on top of the external oblique, and I see some inflammation and waviness in the subcutaneous plane. That's right. This scan is telling me that this patient had undergone an on-layer repair. So the rule of 3 can actually tell you about the approach that was taken. Let's deep dive into the rule of 2. The rule of 2 is focusing on the central compartment, in which we have 2 rectus abdominis muscle in the center, all the way up on the bottom to pubic symphysis, and is actually covered by anterectus sheath all along and posterior rectus sheath till the arcuate line. On the top left, you are seeing an image taken from ETEP repair, where the roof is formed by the rectus abdominis and the floor is formed by the PRS. Now let's put that into perspective and find out what we can see in the central compartment given in a scan. Now forget about the rule of 3, just focus on 2. So we are looking at 2, that is the rectus abdominis muscle and the rectus compartment. This patient has an absent GB. So I know an absent GB and an atrophied rectus abdominis muscle here. When you compare that to the other side, left side, you see that on the right, the rectus abdominis is completely atrophied, and so are the flat muscles. And in the absence of GB, I understand that this patient has undergone open cholecystectomy in the past. These kind of hernias, these kind of anatomic images on CT scan can give you information about the density of the muscle, which is important. So I know for sure that this patient has some component of denervation. This may present to some of us as a pseudo hernia because of the bulges these patients have. These muscles lose their tone and appear very, very shaky. So the tone, because of the lack of tone, these may appear as a hernia, but they're not actually hernia.
Ankit, there's no audio. We can't hear you. So I think the connection with Ankit is lost.
I am really very, very sorry. I have power failure here, and somehow my hotspot is also not supporting me. Can you see my screen now?
No, yeah. Now you are sharing. Yes.
Okay, I'll turn off my video again. So this is an important point here that you have to. When we are closing hernia defects, we are not closing muscle to muscle. We are closing fascia to fascia. And a lot of the times your radiologists will just look at the neck. They don't really understand what we want to know. And that's precisely why you need to bridge that gap. In these, when you don't have the medial support to your rectus abdominis will eventually contract, and so will your flat muscles. Their anatomic appearance on scan will completely change. So you should be actively looking for that. Your hernia neck may or may not be formed by the medial border of the rectus abdominis muscle, like in this very case. Another case, and this is a great teaching point here. This patient had undergone endometrial scar excision, and the hernia is a resultant of that. Normally, what a radiologist would do is measure the medial border of one rectus abdominis to the medial border of another rectus abdominis. But that's not exactly the case here. Let me put in my ugly sketch and explain what I'm trying to tell you. The red is the rectus abdominis muscle and the flat muscles. In the brown, what you are seeing is the fascia, the anterior rectus sheath, which is left over after excision of that endometrial scar. Now you're seeing the fascia is not on top of the muscle. So when you try and close this defect, you have to go far more lateral to close. So let's say on scan, I am seeing medial border to medial border of rectus abdominis is 5 centimeter. But when you measure, according to my theory, the defect will easily become 7 centimeters because you don't really have tissue there. It's all retracted. That's why it's important to understand where are your facial defects rather than the defect or the distance between the rectus abdominis muscle. And that's precisely where you should be measuring the hernia defect. Another scan. This patient had undergone E-TEP repair. Now we are looking at the central compartment. Now I see some densities which is in the middle of the abdomen. E-TEP repair, the Achilles heel is the failure of posterior component, posterior sheath rupture. If you have that, you will find that, I'm sorry about that. If you have that, you will see that your bowels have gone into your posterior component, the medial compartment, which is below the rectus abdominis muscle. And your bowels are hanging in between the layers of the abdomen, that is behind the rectus abdominis, and a floor, incomplete floor of posterior rectus sheath. These kind of hernias are nowadays seen commonly because of more and more adoption of the endoscopic repairs of hernias. That's exactly the density I'm talking about. That should not be there, right? This patient has undergone an E-TEP repair. That is essentially a retrorectus repair. And in the middle of it, you have bowels on either side of it. So there is a partition, and that partition is actually the posterior rectus sheath, which has given way. So this is a classical case of posterior sheath dehiscence. Coming back to one is where everyone puts their attention to, and that's the linea alba. Any hole in linea alba is readily picked up by most, unless it's an occult hernia. In that case, you really should be forcing upon a patient to undertake a second in Valsalva maneuver. And that's essentially will give you certain information about if there is an occult hernia or not. What actively are we looking in the linea alba? The first and foremost is diastasis. Oftenly this was overlooked, but now we know that it's essential to repair any diastasis associated with the hernia. Otherwise, the rate of recurrence or a neoherniosis is above 30%. And it's pretty simple. You take the interrecti distance from medial border to medial border, which is actually the opposite of what I told you while measuring the neck of the hernia sac. So in diastasis, you can do that because you have a facial bridge which is completely intact. You have to repair it, but you have to understand how far lateral you have to go for your dissection if you're doing a procedure like scola. So that's where divided these muscles are up top in the abdomen, which should not be the case. Another case, a lot of the times you will see that there is fatty deposition in muscles. A lot of these young and old patients have to this tendency. Coming back to our some scans that I would want you to see, that here I am seeing that my lateral muscles, if you see the rule of 3, is completely disconnected to 2, that is my medial compartment of rectus abdominis muscle. And I see these hypodense structure herniating into the subcute. But there is more to this scan if you put your eyes into it. I see some waviness. Let's zoom right into it. That waviness is below the sheaths and below the muscle. And that waviness is probably the mesh. I'm not seeing any tacker. So this may not be an IPOM repair. So how do you know what repair it could be? Well, it's actually hard to say because you really cannot define peritoneum, and fascia transversalis in a CT scan. Once you do an operation, finding a mesh is basically based on having indirect signs. Like in this case, the waviness. In other case, you may find some fluid collection or even a scar to tell you if there is a mesh there or not. So we are seeing here a mesh which is going all the way up to the lateral border of rectus abdominis or the linea semilunaris. And right where exactly you find a breach, which may have caused due to an iatrogenic trauma to the linea semilunaris during surgery. There is no mesh coverage there or laterally, and hence we have a resultant hernia. This is the picture that I've adopted, which gives you a brief overview of how your abdomen would look. Actively, we are trying to crack how to make crossover easy for everyone, because most people make mistake, cause pneumoperitoneum, and so on and so forth. So while reading your scan, what can help you in achieving a proper crossover is finding where your falciform ligament is. It has gained a lot of traction of late, and we are actively looking for it. So your falciform up top right there is running across. When you find the scan, you're seeing a density there. Now you may argue this could very well be pneumoperitoneum. No, you should not be saying that unless you put that in lung window. When you are confirmed that it's not air, what remains is fat. So that right there is your falciform ligament. And the fleshiness tells me that in this very patient, crossover is going to be easy. When you scroll down, you can even see ligamentum teres hepatis. So this is important when you are planning a patient for a conventional top crossover falciform ligament. Now you must understand that abdomen is one cavity, one cylinder. So you should be looking from above the liver all the way to the pubic symphysis and pelvis, because you have your diaphragm there and pelvic diaphragm below. Always count the ribs. You may have a thoracoabdominal hernia. That's really, really important. You have two patients. They're of the same BMI. Can you tell me which one will have more SSI, which one will have more chances of recurrence? Yes, your CT scan can tell you that. So CT morphometrics is picking up of late. Now, that in colorectal surgeries, we can predict the chances of having a hernia based on your fat distribution. So on the left, if I tell you, and the right have the same BMI, but on the left, we have more visceral fat, and on the right, I have more subcutaneous fat. The one on the right with more subcutaneous fat is prone for more SSI, but on the left with visceral fat is more prone for recurrence. There are enough papers now that are telling that we can apply this to most ventral hernia repairs, and especially in component separation, where we can find or predict some of the other problems that may happen and optimize them beforehand. So your CT is actually helpful for that. We even know that patients with sarcopenia don't do very well. And your CT, when you look at your psoas muscles mass, can tell you that as well. So CT is actually helping you out in predicting your outcomes too. Complications are inevitable. No matter how well you plan, how well you are trained, how great your team is, complications are inevitable. This case is a case of seroma post-onlay. And you're seeing what here is the thick cavity of that seroma because it's a chronic seroma. You can't see any recurrence for now in this patient. Lower down, you can't even appreciate the mesh. This case was done about 5-6 years ago, and he had been carrying this seroma for now until it's become to the point where he's actually having trouble.
Ankit,
Sometimes, yes.
Time is up.
All right. This is my last scan, wherein you have to be due diligent when you are doing these scans. You cannot leave this on technicians and radiologists alone to find out what exactly is happening with your patient. This patient who has operated thrice has a massive hernia that has left her with dysfunctional abdominal wall and more. So what are these more? These more are these sinuses. If you can see my radio opaque contrast going into the bowel, and if you trace it backward, right there is my needle going through one of the sinus. Now I had to spend about good 30 minutes to delineate this sinus. That's it about my talk. My scans were limited to the scans that we need in planning posterior component separations and anticipating what can happen what wrong can go and assessing the complications. Thank you very much. If there are any questions, I'll be happy to take them.
Thank you, Ankit. I think that was a wonderful talk. And your concept of 3, 2, 1 is very, very practicable, and I am sure everybody will remember it. Dr. Pinnock is asking, if you wait more for these hernias, the rectus muscle contracts and retracts. So is it better to operate early and treat them?
The natural tendency of any hernia is to grow. So any hernia will grow. If you have a hernia which is 1 centimeter today, it will become 5 centimeter if you don't address. Why? Because your muscles, your flat muscles are in constant state of tension, which is the hoop tension. So they will retract and your hernia will become bigger by day. So yes,
Ankit,
I totally...
Can you stop sharing? You can see.
Right away.
Okay, continue.
So yes, I totally believe that if you find a hernia, if the patient is with you, you need to give a solution to that very patient.
Right. Any other questions? So you do all your radiology, ultrasound, and also looking into the everything yourself, Ankit?
Yes, sir, I do. I actually enjoy doing it.
Right.
Ultrasound actually helps me in planning my port positions, deciding where to cross over, and scanning, of course, gives me a lot more details than I can actually think of. So I always put CT scan above, but I don't downgrade ultrasound because ultrasound at times is really very, very handy to do a lot of things, even Botox. We do Botox in the radiology suite under the ultrasound guidance. And our radiologists have been very, very friendly to give us that chance also.
There is a need for surgeons to get trained in the radiology, ultrasound, and CT.
I totally agree. I mean, we are the ones who plan the best for our patients.
True.
And if we are thrown with surprises more often, then I'm sure we put that extra burden on ourselves. We carry that baggage that we could have done this before, but we did not. I think imaging will bridge that gap. I mean, look at all the vascular surgeons who do Doppler themselves because they want to be sure. They don't want to have surprises in the OR. I think we should start picking up that skill.
Absolutely. Dr. Pramod Shinde?
I think the radiologists also need to be trained in reading abdominal wall reconstruction hernias. They commonly give 2 or 3 sentences report. And only when we start demanding, educating, asking for them, giving them papers, references, telling them what we want, then they slowly pick up. There's a learning curve for them also. So I believe even the radiologists need to be trained.
Absolutely.
Very well said.
Many times they don't give importance to abdominal wall, they give importance to bowel and intra-abdominal contents. Right.
True.
Thank you, Dr. Ankit. That was a wonderful talk, and a lot of people couldn't hear properly. If you can share your talk in the group, that will be very nice. Your audio, sometimes it was problematic.
I will
Dr. Prem is ready. You'll be able to share.
Yeah, can you hear me, sir?
Yes, you can hear. Prem. That will be the last talk, Ankit.
It is the last talk of the session.
We can see your slides. You can go to the, yeah. Right.
Yes, sir. So I'd like to thank Dr. Ankit for inviting me to give this lecture here. It's always a pleasure to lecture on the same platform with Pramod sir, Shivaram sir, Dr. Ramesh sir, and my good friends Parthasarathi and Ashwin. All of you have given fabulous talks. Somehow I don't know how I'm going to hope I do a good job after all these fantastic lectures. So when Ankit told me to talk about what's new in posterior component separation, I was wondering what to talk about. But when I did my homework, there is a phenomenal amount of topics that we need to cover. So I don't think I'll be able to cover everything. So rather, we can even call it what else in PCST. I've selected some of important topics which I will cover. I'd like to thank Dr. Pramod and Dr. Ashwin for giving me some of their materials so that I can use in the presentation. Basically, these will be the topics that I'm going to be covering today: the peritoneal flap hernioplasty, the polys parastomal hernia repair, the TAR, the reverse bottoms up TAR, the Mylos TAR, and the robotic posterior component separation. Obviously, I will not be able to do justice in the short time, so I will just be touching up on all these topics so that everyone can have an idea about what all these things mean. Going on to the first talk, that's the peritoneal flap hernioplasty, also called as the Edinburgh repair. See, this is one important technique wherein we can, avoid doing a TAR. So if you notice here, 1 second. I'm sorry about that. If you notice here, this center, this is the hernial defect. So what we need to do is we need to do a midline laparotomy. Save the sac. Don't excise the sac. On one side, you incise the posterior rectus sheath, and on one side, you incise the anterior rectus. Then the side which is opposite will go into the posterior rectus sheath and the suture there. The mesh is then placed over there, and the anterior flap is brought and gone to the anterior rectus sheath on this side.
We can't hear you properly. I think no. I think you can take out your video. You can hear, but your volume is very low.
Can you hear me now, sir? Hello?
Okay, now better.
Yeah. Okay. So basically, that is the concept wherein on one side the anterior rectus sheath is open, one side the posterior rectus sheath is open. The flap on the peritoneal flap on one side is sutured to the posterior rectus sheath on one side. The mesh is placed over that, and then the anterior flap is close to the anterior rectus sheath on the opposite side. So these are Dr. Pramod's pictures. Thank you so much, sir. You can see the flap of the anterior rectus sheath on the left side, and this one you can see the incision on the anterior rectus sheath on the opposite side. Now, the right flap is sutured to the left posterior rectus sheath, and over this the mesh will be placed, and then the preserved left flap is closed over the anterior rectus sheath. This is a fantastic technique in very flabby hernias wherein you can try to avoid doing a transverse abdominis AR. And here you can see that the final closure is in progress. A lot of work has happened in this field in peritoneal flap hernioplasty, and it is a very good technique wherein one can try to avoid doing a TAR repair. Now, this polys parastomal hernia repair was, invented by Dr. Eric Polly from Pennsylvania State University. Basically, in this technique, what happens is it combines a TAR with a sugar baker repair. Mainly, what we are doing here is we'll be doing a retromuscular sugar baker repair, where the mesh is not cut and the stoma is not moved. So, to understand that, we'll have to know what is the sugar baker repair basically. So, for parastomal hernias, you have a keyhole technique and a sugar baker technique. Someone has to unmute themselves.
Come on.
So if you see here the sugar baker technique, it is basically on the principle of an IPOM, wherein you see an IPOM mesh is placed and you have a tunnel between the peritoneum and the mesh there, and the repair is done. So using this in combination with the TAR was what Polly has been doing. What we do is, initially you do a midline laparotomy, go on the retrorectus plane, and you do an anatomical closure after taking down the sac, and then you do a complete retrorectus dissection on that side. Next, you also do initiate the TAR and complete the TAR around the stoma also. If you've seen here, the entire TAR has been complete even around the stoma also. And what you have to do is then transversalis fascia defect, the posterior rectus sheath defect, everything has to be closed, and the bowel loop has to be lateralized as far as possible. Okay, here you can see that the posterior rectus sheath, the transversalis fascia, all the defects have been closed, and the stoma, the bowel loop which is going into the stoma has been lateralized. And you see a mesh is being placed here. The mesh does not go around the bowel loop, but rather, since the bowel loop has been lateralized, anchoring sutures are placed so that the mesh will lie on the mesh like a small tunnel. This will be the final picture. As you can see, the transversalis fascia, the TAR is being done, the mesh over that, and the stoma going through the mesh. There is also a modified technique of polyparastomal hernia repair wherein he detaches the entire stoma, he completely closes off that area, and he goes between the posterior rectus sheath and the transverse abdominis without doing a TAR. And then he places the stoma in the epigastric region, creating a neostoma. This is a modified technique. Some other thing which you have to keep in mind is the SMART, which is also called as the stapled mesh stoma reinforcement technique, or the stapled transabdominal stoma reinforcement technique with the retromuscular mesh. Due to lack of time, I think just giving you all the information so that you can, catch up on all the stuff later on. And Parthasarathi has beautifully demonstrated the term, but I'm so happy to say that, Dr. Ashwin Masurkar was the proponent of this technique and a good friend of mine. And he's been extensive work on this. And this has become an internationally, a well-known technique. And, this paper is in the World Journal of Surgery. And, a lot of talks are also being done on this term, wherein we enter into the peritoneal cavity, and as Dr. Parthasarathi has demonstrated, the transverse abdominis release is being done. Going on to another important technique, which is also called as a reverse TAR or the bottoms up TAR or the Madrid repair. See, the indication for this is the lateral hernias and flank hernias. See, because you have to notice that as a lot of talk has been going on the anatomy today of the abdominal wall, lateral hernias are those hernias which are lateral to the linea semillunaris. And if you try to go out by TAP, and you will not be able to get a sufficient cover of around 5 to 7 centimeters. So when you are doing a bottoms up TAR, you have to start your dissection in the lateral compartment. You have to separate the fascia transversalis and peritoneum from the transverse abdominis muscle. Incise the posterior rectus sheath longitudinally from below upwards, starting at the level of the arcuate line. I will show you the video shortly. And you have to be very, very gentle, because as Dr. Parthasarathi and Dr. Ankit have been mentioned, the transverse abdominis, as it proceeds below, becomes a very aponeurotic and thin structure. So if you are in a little bit of a hurry and if you don't proceed gently, then you may go into the wrong plane. So if you notice here in this diagram, you can see the how the linea semillunaris is formed. You can see the lateral 3 muscles. In the above part, you can see the posterior rectus sheath, and the inferior part, you will see that there is no posterior rectus sheath, only the arcuate line of Douglas. Okay, so if you are to operate lateral to the linea semillunaris, it is not like you are operating, straight away in the in the peritoneal cavity proper, because you are lateral to the linea semillunaris, and you will need to do a TAR if you need to get into that plane. Here you can see the fascia transversalis lying under the rectus abdominis muscle. So your aim will be to operate in the plane between the fascia transversalis and the rectus abdominis muscle after doing the transverse abdominis release. Actually, it's a lateral hernia, not lumbar hernia. I'm sorry about that mistake. So you can see this is a post-surgical incision, and it's a lateral hernia, which is lateral to the linea semillunaris, and you can appreciate the anatomy which was shown by Dr. Ankit previously. So you can see the defect is lateral to the linea semillunaris. So we place the camera port just above the umbilicus. That is the right hand working port. Linea semillunaris there, 9 subcostal cartilage. And that is the hernial defect. So we enter into the retrorectus plane by an optic axis trocar and create the entire plane there nicely and dissect up to the linea semillunaris. You can appreciate the arcuate line there. You have to be very, very gentle here, because if you go in a hurry and try to open up that space and you incise the transverse abdominis, then you will go into the wrong plane. So we need to work the plane between the transversalis fascia and the transverse abdominis muscle. So you have to be very, very gentle at this stage. And this is called as the bottoms up TAR, because it is reverse TAR. We are starting from below upward rather than above below. This is like, your initial port entry for ETEP when you want to enter into the retrorectus space. The most important thing is getting into the retrorectus space without entering into the peritoneal cavity and creating pneumoperitoneum. So how much ever care you are taking there, the similar amount of care and delicateness has to be done at this stage. And as you do on a TAR starting from above, you have to take good care not to damage the neurovascular bundles, and you have to proceed just below them. So this is the lateral compartment of the abdomen, as you can see below, and all that below is, you know, your peritoneum below and the transversalis fascia. So all that is a space which has been created by the hernia, which we will be approaching soon. Yes, now you see, moving on to the sac. See, unlike in other hernias here, you can see now I'm opening just below the neurovascular bundle and I'm reaching the transversalis fascia, which you can see there. Here, the transversalis fascia has actually formed a part of the sac. So unlike in direct hernias, it may be very, very difficult, you know, to separate that sac along with the hernial defect. So you may have to open and enter into the peritoneal cavity, as which I'll be doing here. So that is the hernial defect which I'm encountering now. And as you move upwards, slowly we will be encroaching upon the transverse abdominis muscle. So here I will be opening into the hernial sac now and going into the peritoneal cavity. That is the layer. So we will need to actually want to work between that layer and the transverse abdominis muscle. Now that is the transverse abdominis there, you can see, the transversalis fascia separating properly. And that is the, you can see in between, that is the aponeurotic part of the transverse abdominis, which I will be incising now. And this will develop onto the fleshy fibers of the transverse abdominis muscle as you progress upward. You can see the brown fibers of the transverse abdominis slowly coming into view. The transverse abdominis muscle is visible now. And you can appreciate that clearly now. Now the transverse abdominis release will be started upon. So we have to create that plane and go in between the transverse abdominis and the transversalis fascia so that you can get a good dissection all around the hernial defect. So that is the, gently we are separating the transverse abdominis fibers, as Parthasarathi also had demonstrated in his video before, and creating the spaces. So that is the plane which you need to operate upon. These are the buttonholes which Dr. Ankit was talking about, and these should never be left alone, and all of them have to be closed precisely after the end of the dissection is over. So now once the dissection, everything is complete, you can see the hernial defect there, and I've got a good margin all around the defect. Now the posterior layer is being closed with barbed sutures. That is the final suture there. Now the hernial defect will be closed with a long-term absorbable V-lock absorbable suture. And finally, the mesh is placed. I would prefer not to anchor the mesh inferiorly because the nerve bundles, maybe neurovascular bundles will be there. But towards the medial end, I anchor it either with suture or a tacker. And you know, the whole thing is desufflated under vision. Someone needs to unmute themselves, please.
Raman, you have to mute yourself. Thank you.
And under vision, the entire space is desufflated. So there's another technique called as the Mylos repair, which is the mini or less open sublay repair, incepted by Wolfgang Reinpold, Dr. Bittner, etc. Here it is an endoscopically assisted operation, where it is an operation which is done through the transcorneal sac. They have specialized instruments which have an endoscopic light tube and light carrying instruments which are used in this operation. So it has, the advantage of both open sublay and a laparoscopic IPOM repair. This is the specialized scope which is used there, and they're entering into the hernial sac. Basically, they enter into the hernial sac here, and they operate in this space, and they use these specialized instruments. And then, they can, go between the retrorectus space. They can do a TAR, etc. And the remaining thing is as similar as they do in the regular surgeries. Finally, we have robotic posterior component separation. This is actually the E-type approach, which Dr. Parthasarathi was mentioning, but he didn't demonstrate. So this is the robotic technique. It can be done laparoscopically also. As we all know in robotics, you have the advantage of 3D vision, and you can see the fantastic magnification here, and the operation can be done very precisely. And another advantage of the robotic technique is that, there is no conflict between you and your cameraman, because you are your own camera person, and you can actually, have a good vision. And right now, this is the crossover which Dr. Ankit was talking about, which has to be very precise, where mistakes should not be taken. Identify the falciform ligament, as you can see there, and stick to the top part of the falciform ligament. And you can see the crossover being done into the opposite area, and you can even identify the rectus muscle of the opposite side. So the dexterity of the robotic arms are excellent, and they help you to dissect very nicely in all the planes. And in fact, normally the operation which we take, three ports in the upper quadrant of the abdomen, 3 ports in the lower quadrant of the abdomen for doing E-TEP, TAR, etc. Actually, in robotics, actually, you can actually just manage with lesser number of ports, and you can see the large hernia here, which is being dissected. Another advantage of the robotic technique, obviously, is the dexterity and ease of suturing, particularly in E-TEP ventral hernias. All of us know what a technically demanding and stressful operation it is. So the robotic technique really, makes it much more easy and makes suturing more easy, and really eases the strain on the surgeon and gives very good functional outcomes. So that is the posterior rectus sheath being closed. This is a very highly edited video, just just to show you the advantages of the robotic technique and its implications. So this is the PRS being closed. And you can see the dexterity and how useful it is, the movements of the robotic arms, and it makes suturing extremely easy. And finally, that's the mesh being placed. So in a short span of time, I just tried to give you an overview of what else is there in posterior component separation technique, but there is definitely a lot more. And those of you who are getting interested in the field of AWR, there's just fantastic things to do in AWR. It's not just a few things alone, and there's a lot more to go in this anterior posterior component separation technique. Thank you so much.
Thank you, Dr. Prem. Thank you for that concise lecture in showing us the way forward and what's new in component separation. Do we have any questions for Dr. Prem?
The host has to start my video.
Dr. Prem?
Sir, you have stopped my video. You have to release it.
Yeah, I will stop. So in the lateral hernias, how far you go laterally to place the mesh, and how you get the sense how much where you have to stop in the TAR?
So, see, we can go like Dr. Partha was saying, when you're doing a posterior component separation, you can go all the way up to the iliosova, the quadratus lumborum also, but ideally, you can just have a ballpark figure around 5 to 7 centimeters on all sides, and that should be more than enough, sir.
Right. Ankit, any other questions?
That should be it, sir.
Nice presentation.
Right.
For joining us on this first AWRSC South Zone webinar or concepts of components. There were technical glitches, and I assure you they will be looked after seriously by the team, and we'll come back with the bang next time with even more concise and to the point topic. Thank you all very much and have a great Sunday evening. Over to you, Dr. Shivaram.
I think we had excellent participation. There were people waiting here and a lot of people logged into the Facebook also. Thank you all for participating in the large numbers. I'm sure it was useful, and every speaker has put in a lot of effort and they have brought the best from their center. Thank you all. Thank you very much. Thank you, Dr. Shinde and Dr. Punjani, encouraging the South Zone. Thank you very much.
Thank you. It was a great program. All the talks were very nice and useful also.
Right.
Thank you.
Dr. Ramesh.
Thank you.
Thank you. Bye. Thank you, sir. Thank you so much.
Thank you, friends. Bye-bye. Stay safe.
Thank you.
You all. Take care. Bye-bye. Thanks. Have a great Sunday evening, everyone.
Thank you, Ankit.
Thank you. Bye. Bye.
Fantastic job.
Thank you. Thank you very much, sir.